Welcome, everybody. The in-public meeting of NHS Tees Valley Clinical Commissioning Group. I'm Bolesław Posmic, salaried GP in Haworth near Darlington and Hartlepool, both in not full-time. And then I'll go through my list of everybody who's present, so people can introduce themselves, because we've got a few non-governing body people at this meeting. And for those of you who joined recently, the meeting is being recorded, and that will eventually go on the CCG's website. Okay, so that was myself. We've got Tees Valley Clinical Commissioning Group Corporate Governance, who are basically acting as the host and doing the recording. So, Janet Walker.
Thanks, Paul. Sorry. Medical Director of the Tees Valley CCG. Good afternoon, everybody.
Okay, Mark Pickering.
Hi, Mark Pickering, Chief Finance Officer for the CCG.
Michelle Thompson.
Hi everyone, I'm Michelle Thompson. I'm the lay member for patient and public involvement for the CCG.
So TV CCG Corp Gov.
Hi, I'm Lynn Pearson. I'm Corporate Secretary and I'm taking the minutes today.
Okay, Karen Hawkins.
Good afternoon, Karen Hawkins, Director of Commissioning for Primary and Community Care.
David Emerton.
Hello, I'm David Emerton, Secondary Care Doctor on the governing body. It's non-executive role.
James Nevison.
I am James Nevison, a GP from Darlington and a non-executive member of the governing body.
Ali Johnson.
I'm Alistair Johnston, a GP in Thornby and Ingerby and a non-executive member of the governing body.
Caroline Gisham.
Hello, I'm Caroline Gitcham. I'm a lay member on the governing body and chair of the primary care committee.
Craig Blair.
Hi, Craig Blair, Director of Commissioning for the CCG.
Karen Dales.
Hi, Karen Dales. I'm a lay member and audit committee chair.
Joanna Bushell.
Afternoon, Jo Bushnell. I'm a clinical pharmacist in Darlington and Stockton, and I'm a non-executive member of the governing body.
Sue Kirk.
Hi, I'm Sue Kirk. I'm a volunteer with Healthwatch Darlington and Darlington Community Council.
Hi, Andy.
Hi everyone, I'm Andy Mackay. I'm the independent member for the CCG.
Hi, Hassan Tahir.
I am Hassan Tahir, GP in Stockton and non-executive member of the governing body.
Spring P49.
Hello, I'm Penny Spring, Director of Public Health for Darlington.
Hi, and Jean Golightly.
Good afternoon, everybody. Jean Golightly, Director of Nursing and Quality for the CCG. Apologies, I just couldn't get in on the link.
Yeah, I managed to get back in, so that's great. I've also got apologies from Alex Sinclair and also from Dave Gallagher, our accountable officer, who is attending another meeting with the chief execs of the Tees Valley for between 2 and 3, but he'll be joining us later, just after 3 o'clock shortly. Okay, so please, if you could make sure your mobiles are either not in the room or you've got them turned off, if possible. Ideally, blurry background or Tees Valley CCG background if you've got it. Also, please, if you could pop yourselves on mute as well if possible, because it tends to cause feedback. I can see just about everybody. Yeah, everybody's got their mics on mute. And then if you use the reactions little icon down at the bottom of the screen or raise your hand where I can see you if you're wanting to speak or make a point. And then if you're needing to leave your seat during the meeting, if you turn your mic, make sure your mic is still on off and turn the video off as well, just so we don't see or hear things that we're not supposed to see or hear. Okay, for those in attendance at the meeting, there'll be a section at the end of the meeting where I'll invite comments, questions from yourselves, from the members of the public in attendance. If who wish to speak. Okay, so meeting is quorate because we've got Mark as one. I saw Mark earlier. Yep, there he is at the top left of my screen. We've got 3 clinicians, we've got non-executives in the appropriate numbers, so we're quorate. Okay, and I've not had any other business notified to myself apart from what was in your agenda. So, declarations of interest. We've attached the conflicts of interest register to the papers. Also got extra declarations, patient and public involvement update report. Lay member for patient and public involvement. Michelle is the chief exec of Healthwatch Darlington, and Healthwatch Darlington has received a grant from the CCG to deliver a program of engagement activity in Darlington. The report doesn't make recommendations to commit any extra funding to organisations, and Michelle is also a patient and public voice for NHSX and a non-voting member of the Northern Joint Clinical Commissioning Group Committee. But there's no conflict that I've identified that sort of prevents Michelle from speaking or taking full part. There's also item 50, the Integrated Care System Development Health and Care Bill. Ourselves as governing body members are potentially impacted by this, but there's no specific decisions to be made, so I don't think there's any particular conflict of interest that directly affects our ability to discuss this. But if you think of any other conflicts of interest that arise as we're speaking, please raise them. And does anybody want to raise any extra conflicts of interest that haven't been declared previously? If you wish to speak now, please do. No microphones coming active or hands raised. Okie dokie. Right, so if we go on to the minutes of the previous meeting, if you just bear with me while I scroll past the conflicts of interest register. Okay, minutes. Page 8. Page 9. Page 10. Page 11. Yep.
Pause, just an amendment to the minutes, please. It was myself, Andy and Michelle that did your 360. Andy's name's just dropped off it, so if we can just include him in, that'd be great.
For the sake of accuracy, you did my appraisal. Other members of the governing body and the executive did 360 feedback.
Yep, great.
Yes, right. Yep, okay, so if you tweak that, please. Right, that's page 11, page 12, page 13, page 14, page 15, page 16, page 17, page 18, page 19, page 20, page 21, page 22, 23, 24, 25, 26, 27, 28, 29, 30, and 31. So is everybody happy that that was an accurate representation of our discussion, apart from that small adjustment as suggested by Caroline? Everybody happy with that? Yeah, yeah, nods around, okay. And then there's the second set of minutes from our EGM where we went through the reports. Okay, so, oops. Just scrolled a little bit past that. Okay, second set of minutes, page 32, page 33, page 34, page 35, page 36, and page 37. Everybody okay with that set of minutes as an accurate report? Everybody all right? Shake your heads or nod. Okay, nod. Okay, nods all around. Thank you very much. And then our action log. Sorry, there is one little bit in the minutes, apologies. Alex Sinclair's requested amendment to paragraph 10.12. Mr. Sinclair highlighted that the new neurodevelopmental pathway for South Tees was due to go live as September 21, and the CCG has been working closely with the South Tees Parent and Carer Forum to ensure that the communications were as clear as possible following their feedback. So that's a slight tweaking to the wording. David, you've got your hand up as well.
Yes, that was regarding the first of the points of action. I had some conversation with Alex, so just to clarify when we're ready for that.
Yeah. Okay. And then subsequently there was matters rising in action log, the SEND special educational needs.
Yeah. As I communicated with Alex, the point I was making, it wasn't to do with what the local authority had submitted. That was submitted in full. It was the briefing paper that had the SEND, so she was going to amend the briefing paper, so that action is completed.
Yeah, thank you very much. And then there's the annual report and action by Jackie Keane, and that's been completed. So, moving on to my report. And evidently, things have changed rather remarkably since my previous report, in that we were discussing how things were beginning to ease from a COVID perspective, and there has been a significant easing of COVID restrictions. But unfortunately, the thing that's been affecting the entire country, let alone our CCG or NHS and social care, and every patient in Teesside, it's the countrywide, there's been a significant rise in COVID cases. So Lynn, if you could pop up the slide just now. And this is a slide that I saw a day or two ago. Hopefully you can see that. In that, interestingly, the dark red trace is the number of cases that has been rising significantly. Now, recent reports is that it's dropping back down again, but this slide was as of a period of time last week. But there is definitely a unlinking or a decoupling of the number of hospital beds occupied, which is the green line. So if you look back in previous peaks, the level of hospital occupancy was significantly higher than it is now for the same number of COVID cases present in the population. And additionally, the vertical black lines do point out the fact that also there is a significantly lower number of deaths, fortunately, from COVID, despite the significantly high numbers of COVID cases going around in the community. Thanks, Lynn. So if you could just go back. Yeah. So we're in a situation where we've got significant cases rising, especially amongst unvaccinated people in the population. And the particular thing to note that's affected everybody, but particularly from a healthcare perspective and the services that we commission, is the number of people needing to self-isolate as a result of either having COVID or being a contact of having COVID, which has led to a very significant impact on hospital, community, GP care, amongst others. And indeed, I've been around a few practices, and I've been told of teams being reduced to near skeleton numbers at times in various different situations. So the thing that we really need to remember and stress and point out to people when we can is, do remember hands, face, space. You still ideally need to be wearing masks in the times that we previously were wearing masks. Personally, I don't think it's a mega deal to wear a mask at all times that you previously wore. So if possible, please stress this to people that you work with, contact with. But I would like to thank the members of the public who are adhering to the restrictions, or who adhered to the restrictions during the past phases of the pandemic and are adhering to the recommendations now. Okay, so that's the main thing that's ongoing. Governing body working, we had an extraordinary governing body meeting to approve the annual reports and account, which we just discussed. And we've also just held the CCG's annual general meeting, where the annual report was presented. And indeed, it had a very good attendance, and gratifyingly, particularly so from members of our member practices. So it's mentioned in more detail in Dave's report, but along with other chairs and colleagues, we met with Sir Liam Donaldson as part of the engagement process and development work for the development of the upcoming ICS. He's been doing this on a sort of effectively integrated care partnership footprint, so our Tees Valley ICP area. We shared views regarding the process leading up to the establishment of the ICS. And the thing to particularly note was the shared desire amongst everybody there to keep a place-based focus, but also keep the best part of the Tees Valley system, the best working parts, move what we can effectively into the new structure, to keep the working parts going. And additionally, we noted the need for the population of the Tees Valley to have an equitable needs-based proportion of the resources available to the ICS. I've been taking a little bit more time over my report because with Dave being absent at the moment, his report is on paper, and I'm happy to take any questions on my report or on Dave's report from yourselves now. No, okie dokie. So if you have any questions on Dave's part of the report, if necessary, we can take them right at the end of the meeting, because Dave will be rejoining us after 3 o'clock. So moving on, skip the Chief Officer's report as a verbal discussion of the attached paper, and we'll move on to Janet Walker for the locality update. Over to you, Janet.
Thanks, Paz. And actually, you've already said some of the themes that I was going to bring out today, and apologies, I am going to repeat some quite deliberately. Understandably, practices are suffering from the same workforce crisis that is happening to other areas across the health and social care system. And we are working closely with our practices and making sure that they're using their business continuity plans to make sure that they are able to continue to deliver core services, recognising that there are many staff who are isolating, and indeed, many staff who are on annual leave. And understandably, after the 15 months that everyone has had, it is completely appropriate that people do still take their annual leave. And it is obviously that balance, but it's crucial to our staff's health and well-being as well. We are asking in primary care, that's general practice and other elements of primary care as well, that patients, carers, anyone who's attending primary care still comes wearing a face covering to protect themselves and those who could also be in the waiting room and the other common services around and about them. And that is something that, yes, we make no apologies about doing it. It does fit with government guidance that anyone attending a health setting should wear a face covering, and we would encourage everyone, as Paz has already said, to make sure that they continue to follow the appropriate infection prevention control guidance that helps to keep us all safe and, most importantly, protect those more vulnerable around and about us. From a practice point of view, obviously the practices and PCNs are continuing to beaver away delivering COVID vaccination. That programme continues to run on at full pelt. At the last governing body, we updated about some other initiatives that we were putting into place to make sure that the vaccine programme had the greatest in reach and outreach, whichever way you care to look at it, into some of our populations that haven't found it as easy to come forward for their vaccination, and that effort continues to be ongoing. As we've moved into the younger cohorts, we have had to change some of our approaches, and you'll probably have seen on the news a variety of different ways that we're doing this by the use of different vaccine buses. The Middlesbrough Football Club bus was out yesterday and today, and the Northumberland vaccine bus is in Darlington today. So there's a variety of different approaches that help to support everybody who's eligible for vaccination to come forward. Practices are planning for their involvement with the delivery of a COVID booster programme, which will be running alongside that continued evergreen offer, so that anyone who hasn't already come forward for their COVID vaccination, be that for their first dose or indeed for their second dose, that offer is there. Yes, we want you to come forward, even if it takes you a little bit longer to get happier and comfier with it. Yes, and we'll try and make sure that the approaches for you to be able to walk in and have it are as manageable and easily accessible to all. Also, significant ongoing planning with regard to how we will incorporate the new guidance from the JCVI around the vaccination of selected groups of children. And yes, that is something that will be planned on a larger scale basis to make sure that yes, we help to protect our vulnerable children before they return to school as September progresses. Thinking and planning and practice is also going on at the moment with regard to flu vaccination. Absolutely, it's all wrapped up with what can happen at the same time as the COVID booster programme, and making sure that, yes, we're wanting to protect our health and social care systems against the impact of infections over the winter months. And it is making sure that as a system, we try and coordinate that as best we're able to make sure that, yes, that the huge numbers of patients, residents that need to be vaccinated are vaccinated in a way that the system can hopefully manage as smoothly as it possibly can. But obviously, yes, significant challenges ahead with that one. Our practices are continuing to engage and work with our local hospitals. The PCNs, which are the primary care networks, are continuing to work with the community teams within the hospitals to get those relationships better solidified, to make sure that we're delivering care around the patients in a coordinated way. And there's a variety of engagement events that are planned with the trusts, one of which, from North Tees perspective, is going to focus on respiratory syncytial virus and education for all primary care staff, be that nurses, nurse practitioners and GPs, to support our individuals. Again, all as part of trying to make sure that we manage our winter pressures to make things as smooth as we're able to as we move from what I know is the middle of summer, but we're all thinking well ahead, because unfortunately the pressures in practice at the moment, as indeed across the health and social care system, are exceptionally busy. Understandably, the 15 months we've had, people have presented in different ways, and yes, there is a lot of need out there, and understandably it is putting all systems under pressure, and it's how we continue to make sure that we use clinical prioritisation to make sure that those with greatest need are able to have their needs met in the best way that we can across primary care. Now, they were the main things that people had fed back to me, Pos, but understandably, if anyone wants to ask any questions, very happy to take questions.
Okay, folks, any questions for Janet? David, I think that's, yeah, David.
Yes, thanks, Janet. It's really just a comment, looking at the statistics on the SharePoint for secondary care, similar pressures on secondary care. The acute trusts have got several hundred staff members in total off for COVID-related reasons at the moment. Earlier in the week, there were about 90 inpatients with COVID in South Tees, about half that number in North Tees. Not as bad as the winter peaks, but it's summertime when staff are taking annual leave. There's considerable pressure on secondary care as well as primary care. So just to echo that point for public awareness, to have that regard towards secondary care as well as primary care. Thank you.
Thank you, David. I entirely agree, and I do beg your pardon. Yes, I had meant to stress that it's across the whole system. It's all of health and social care. We know that social care are also really struggling for just the same reasons, and it is how we can all make sure that we try and get the best use out of all our services. One thing actually, Paz, I do beg your pardon if I may, also just to raise the COVID oximetry at home. Not surprisingly, with our latest peak, we have had much higher numbers on the COVID oximetry at home programme, and I'm glad to say that this week they are lower than they were last week, as they were approaching, you know, the upper levels of capacity last week. And I think we're all hoping, aren't we, that hopefully those rates will start to come down.
Absolutely. At least if the rates come down, even if it is for a slightly longer period of time, that will tend to reduce the pressure by way of numbers of people having to isolate. And certainly the other thing that's useful now is that there is a development of a process whereby people who are crucial to the operation of various essential services, not just healthcare, but others, but certainly from a healthcare perspective, for them to be brought back into operation, providing appropriate risk assessments are made and the appropriate testing process in place. Janet.
Just to stress, Paz, that is indeed one thing that the government have released for us to have as a consideration as to how we can support maintaining vital, critical, crucial services. However, for staff that could be potentially exempted from the legal duty to isolate, there are very strict criteria around that. And it's set out in a very rigid risk assessment process that the DPHs have been involved with us developing to make sure that we do keep all our patients and staff safe. It's getting that balance, Paz, but it is a tool that will hopefully help us to use that to prevent vital services having to be shut or closed.
Yeah, Janet, sorry, for benefit of public members who may view this meeting at DPH.
Terribly sorry, Director of Public Health, terribly sorry, yeah.
Thank you. Okay, so any other questions or observations? No, thank you very much, Janet, for your update. And now moving on to patient and public engagement report. Michelle.
Thanks, Paz. So to start off with, I've just given you a quick rundown of the external meetings and events that I've recently attended. And this, for me, is really valuable because I go from local to regional to national and get a real insight into the ever-changing NHS landscape. But that also helps for me to understand what it's like for patients and the public as well. I can see, you know, plans coming from national down to local and how, you know, they may differ, what's actually happening on the ground, but then also going on the way back up as well. So that's just to give you an insight of what I've been attending just recently. At the time of writing this report, I could only write a little bit about the Darlington Community Council, the Health Ambassadors and the South Tees patient groups, but I'm pleased to say that since then we have had quite a few meetings, and I'm really pleased that each of the 3 patient groups have been able to recruit some more volunteers. And what was really good, and this was instigated by Jake, our comms and engagement officer, was a meeting with officers within the CCG, which gave them a real insight as to how they could possibly use the 3 patient groups going forward, as well as, you know, sort of other things that are out there. But it gave a real insight to the officers. And what we've decided to do is to share work plans, which will help volunteers to have a view on what the CCG is looking at or not looking at, as the case may be, but also for Healthwatch Darlington, Healthwatch South Tees stroke Pioneering Care Partnership, and also Catalyst to share their work plans as well. There was quite a bit of discussion about what is also happening anyway, and it could be that rather than duplicating engagement, there could be engagement that's already going on out there in the community, but also there could be reports on, you know, from Catalyst or from the health watches across the Tees Valley, as well as the voluntary and community sector, where there's already an insight into patient and carer and public opinions and concerns about a particular particular project. So it's just really working together to make sure that the CCG is gleaning as much information as possible going forward, but also for the officers of the CCG to be aware of the patient and public involvement governing body report as well, because there's a lot of information in there that they could then get in touch with the other health watches to have an update. And also with the voluntary and community sector, actually understanding them more, because they're delivered to specific groups in the community, and also the independent health watches who don't deliver services but do have that statutory function. So it was just getting a real good understanding of what's out there. So I'm really pleased with that, and hopefully the volunteers that are involved will be able to get more involved over the next 8 months or so in the different work plans. Also with the health watches, hopefully you've been able to have a good read through what they're actually looking at. But for word on the street, the main things that are jumping out at the moment are dentists and also mental health services. There seems to be quite a lot of frustration around that, but it's just so that you're aware that all of the health watches, the 5 health watches across the Tees Valley, are working with CHUV about community transformation. So between now and October, there will be some engagement about how people want to access services in the community. So hopefully the frustrations that are out there, they can see that something is actually happening, and as an independent voice, Health Watch will be able to help CHUV as well. So that's about it really for the patient and public involvement report, but if anybody's got any questions, I'll be quite happy to answer them.
I've got one question. What element, or was there any indication from the dental services perspective whether this was a recent issue? Because I suspect that dentists, along with all the other health and social care providers, will be potentially being impacted by staff absences. Was there any information in relation to that?
No, this is something that's been ongoing, but it seems that people are getting more and more frustrated just recently, because coming out of lockdown, they're wanting to go and get the teeth seen to, and they're not being able to. And, you know, and I think it's delving into it. I'm sure that Health Watch will be able to delve into it a little bit more, just to find out if it is about staff shortage or whether it's just one of those things. It's just they can't get NHS places. It's all private.
Okay, Karen and Mark.
Yeah, thanks, Pos. It was just to pick up in relation to, just for some reassurance both to the governing body and also to the public in terms of the reference to the word on the street around GP closures, and particularly in South Tees. The elements that have been identified, there are no GP closures from a CCG perspective. There is a contract hand back, and we're out to emergency procure a new provider for that practice, and that's currently undergoing at the minute. And the other element is there is a practice that has put forward a proposal and are undertaking engagement regarding closing a branch practice. The main site intends to stay open, and the branch practice closure is being proposed and engaged upon in South Tees at the minute by the practice. The CCG hasn't yet received the business case and won't be able to review that and determine a decision until October. So it was just to reassure the committee and the public that at the moment no practices within South Tees are closed.
Thanks, Karen. Mark?
Thanks. It was just to check, I guess, with Michelle that it's helpful to understand the concerns around dentistry, but just to double check that that's been fed back to NHS England as the Commissioners of Dentistry Services as well.
The various health watches, they will get in touch with NHS England, but also Health Watch England have also done a report on dentistry, which will also have fed in from a national point of view, which may well have picked up some of the local issues as well.
Thank you.
One question for myself, Michelle, is there a general feeling in the public at all that there is an excess of information going out about COVID, the necessity for practices to work differently because of the staff numbers, and particularly also there's too much information about where people who haven't been vaccinated can get it, or are we doing enough or too little?
I would say that people are generally confused about the guidance that's coming nationally, and I think that we really need to just concentrate on that local message. You know, some people may not put two and two together with, you know, sort of the pinging that's going on, and then, you know, sort of people that work within the NHS having to self-isolate. So they may not be putting two and two together as to that's the why that they can't get into particular services. But I think from a CCG point of view, the communications that have been coming out and then being shared across social media have been great. So we haven't really had any feedback from that. I think it's more from a national level. People are just informationed and confused, informationed out and confused, should I say.
So presumably our plan is to keep messages rolling and tweak them as and when necessary according to the situation. Yeah.
Yeah, I would say absolutely. And with the 3 patient groups at the CCG, across the Tees Valley, I think that is a good conduit as well for getting that information out into the community. It's literally from the horse's mouth, which is what we're wanting. So yeah, that I think communications verbally will improve because of that. But I think Jake's doing a great job with the social media stuff as well.
Yeah. Okay. Thank you very much. Anybody else with any questions or comments for Michelle before we move on? No? Okay, thank you very much, Michelle. Noted and discussed. Thanks. Over to Craig and Mark for financial and operational plans.
Okay, thank you. Is there a presentation to pop up for this one, Lynn? Great. As if by magic, it appears on the screen. Fantastic. Thank you. So I'll do the first few slides around finance, and I'll hand over to Craig if that's all right. The initial slide, probably the initial few slides really are a bit of a rehearsal. They are a confirmation of what's happened previously. Last time we considered the financial plan, we were at the point of submission, and I said I would come back and just reiterate the final plan that had gone in. So this is what we're showing here now. Okay, next slide, please, Lynn.
Has that worked, Mark? No. Bear with me.
It's okay, don't worry.
I'm going to stop sharing for 2 seconds, and I'll come back to you.
We'll chat amongst ourselves for a moment.
That's all right.
Yeah, so we're still on H1 and H2.
It is, yeah, and the terminology is interesting, isn't it? So H1 is an area where we have more certainty. So that's the 6 months for April to September. H2 is where there is a little more lack of clarity. So I think that's where we've struggled a little bit.
Yeah, and I suppose, to be fair to the government, the level of change of the situation, as reflected by the difference between my chair's reports of 2 months ago and now, is quite significantly different to what most people were probably expecting as well.
Yeah, I think so. I think as a CCG, we're operating in an environment where we're reliant on our funding streams from a national level, but those discussions are quite challenging because they need to react and respond to the nature of COVID on the ground. So that's what makes it quite tricky at a national level. So I'll talk through the slides as I recall them whilst.
Mark, just to let you know, one of the girls is going to pop on. I've just asked one of the other girls to pop on and do it. Jane's going to hop on, see if she can do it from her end. She won't be a second.
That's right. I can give you some background anyway. So in terms of the Tees Valley, just a reminder that we are operating at a system level. Excellent. So we're operating at a system level for not only the Tees Valley CCG, but also for Tees Valley ICP, the Integrated Care Partnership, so across the NHS trusts as well, and also in the wider integrated care system. So we've got those different levels of finances that we're working with. The plan that we put in that we're discussing here was the initial plan. The world moves on as we go through the various months because there are national funding streams that we're able to draw down but also get pushed out towards us. So this is the initial plan, but as we look at the financial figures as we go through each month in the finance reports, they will flex according to those allocations that come through. Next slide, please, Lynn. This is the summary of our 3 levels that we're operating at, and the little box on the right hand side just confirms where we are really in terms of operating as a system with an integrated care partnership financial envelope, and that covers not only ourselves but also the 3 foundation trusts, as in Tees and Wear Valleys, North Tees and Hartlepool and South Tees Hospitals Trust. And we're all part of the bigger North East North Cumbria ICS. So I've laboured that point a bit because it's important in terms of how we're monitored and almost answering the exam question in terms of our plan. Next slide, please. And again, please. So Appendix 1 here just shows the revenue budgets. These are as per the figures that we saw earlier in May. So there has been no change to those, which is good news in terms of some certainty. And what this captures is the financial figure for the CCG, which is an in-year planned deficit. And remember, that's for the first 6 months of the year. Whereas our NHS Foundation Trust colleagues are planning for a surplus of just around 4.6 million. So overall, the exam question was for us as a system to get to a balanced position, and that's what we have achieved in terms of this plan. Next slide, please. Now, in terms of H2, so the October to March period, at the moment we don't have allocation figures for those. Discussions are still ongoing nationally. Some of the things we do know is that the current regime where we pay block payments to NHS providers will continue. We will continue to get a financial envelope as a system, so that integrated care partnership system level, but there will be adjustments to that in the second half of the year, variously described as what we used to know as QIP, but maybe called efficiency and maybe called waste reduction, but it amounts to the same issue in terms of some financial challenges in there. There will be some money for COVID allocations, and it may be beneficial, I guess, that we wait a little longer for some national negotiations to complete to understand what that COVID money will look like, particularly as we see some of the more recent surges in demand. The elective recovery fund, which you'll recall is around moving further faster with some of the planned or elective activity, is expected to continue, but the thresholds for drawing down that money will increase. So the expectations around levels of activity increase. And again, it's useful to have that little bit of extra time to see how COVID surges in emergency activity might impact on that as we go over the future months. So we're expecting to know what H2, so the second half of the year, looks like, probably not until September. So there will be a bit of a condensed planning section of work to do at that time. We've got a financial deficit position, and therefore we'll be generating a financial recovery plan, but we'll do that alongside our system partners in the NHS trusts that I've mentioned before. And because of that lack of certainty currently around H2, we will be looking to do some financial planning for 22-23, but that's likely to be in the final quarter, so it will be January to March period. So that's shared with you really to reiterate where we were financially, but also to give you some of that emerging information about the second half of this year to sort of set some context for some of the slides that Craig's going to run through. Do you want to go on to the next slide, Craig, at that point?
Cheers, Mark. Okay, I think
apologies. I think it's logical that we bring David in. He's got a question in relation to Mark's point just now.
Yes, thank you, Mark. You didn't refer to the recent 3% pay rise for NHS staff. Do we have clarity yet whether that will be completely covered by additional money from central government, or will some of it be expected locally?
The short answer is that we don't have clarity, but there are two elements that we don't have clarity about which might offset one against the other. One is, will there be sufficient or dedicated funding for that, yes or no? We don't know. And secondly, we also don't know what that efficiency waste reduction factor might be. So there is a chance that one might offset the other, but we'll probably know that over the coming weeks, David.
Thank you.
Anybody else, any questions in relation to Mark's section specifically? No? Okay, Craig.
Cheers, Pos. You're going to have to bear with me because I'm trying to screen share and I can't see hands or anything like that going up as well. So
Right,
just shout up if...
I'll keep an eye out for hands.
Thank you. Okay, so start with a quick recap similar to Mark, really. The slide, you probably can't read the slide, but that's okay because it's all information you've had previously. So back in April, Mark and I came and talked through the process we were working through with ICP and ICS colleagues to develop the plans that were required for submission. So I've just included on the slide there a recap of the guidance that was issued, the timescales we were working to, what the requirement was, and the local governance arrangements we'd put in place to help ensure that we had a collective ICP position produced. So I think what's important now is where we've got to and what did we actually need to submit. So there were 4 elements to the plan that were required: an operational plan, a workforce plan, a mental health workforce plan, and an overarching ICS narrative document, all 4 of which were submitted at an ICS level, but broken down by provider and clinical commissioning group. A little bit different from in the past. We've previously submitted CCG plans, and they've been aggregated up elsewhere. This time round, it was an ICS, an integrated care system plan that was submitted, and within that, you could then disaggregate that down to CCG level. So a slight change. As Mark's already said as well, there was a massive caveat around the fact that the funding that was made available was only for H1. So all of the activity and performance metrics we're working with were based on some assumptions around funding continuing or different funding coming in different parts of the year. So where did we get to? Well, we successfully produced an operational planning template, and we were able to submit activity in line with what the regional and national expectations were. On the slide in front of you now, I've just provided a very high level overview of how each of the CCGs and ICPs across the region completed that task against a number of different points of delivery. So these are activity points of delivery, including first outpatient appointments, follow-up outpatient appointments, total outpatients, electives, that would be inpatients and day cases, non-electives, i.e. emergency admissions, and A&E attendances. And what you've got on the screen is compliance against previous expected levels of activity. So for example, first outpatients across the northeast, North Cumbria, the expectation was we'd reach 87% of historic activity levels. So the baseline year that we were using for this exercise was 1920, i.e. pre-COVID. And all of the providers made submissions that were in line with NHS England requirements. There was a change to the South Tees submission, the final submission that went in, and that's why South Tees is highlighted as red. That was down to some technical issues with the submission process. Similarly, we were required to put something similar in around diagnostics, and I've provided the same information, so you've got a comparator across the northeast and Cumbria as to where each trust was planning to get to. There were some specific challenges for individual trusts around different types of diagnostic activity, and that was in direct relation to some of the change pathways and some of the impact of COVID in terms of stepping up and stepping down services. But we broadly got to where we needed to be in terms of the submission, and we're working towards delivering against those standards now. Just moving on, a key factor in elective recovery is around the elective recovery fund and generating sufficient activity to bring funding into the system. And back in April, May and June, we worked through a series of trajectories which are shared on the screen now. Each bit of the system was working to ensure that we delivered against a number of targets, so ranging from April through till July, we were given a standard to hit in terms of delivery of the previous, the baseline year's activities. So for April, we needed to deliver 70% of the activity, rising up to 85% by July, 5% increase month on month. Mark's touched on some of this, but we worked through some elective trajectories and outpatient trajectories that got us to where we needed to be as a North East and North Cumbria system. There is a breakdown of that by ICP. So looking at the South ICP, you can see that we broadly as a system get to where we need to be. There is some variation between our providers, and there is some different representation of the activity based on which provider you're looking at as well, due to the way that different providers have calculated their monthly activity differently. We have some complexities around the number of working days in a month, POS. So sometimes the providers take account of working days and smooth out the variation. Sometimes they don't. And on this occasion, one of our providers did and one of our providers didn't, hence the reason the trajectories look slightly different. But in terms of the combined total, we get to where we need to be. Non-elective activity, similar sort of approach, and just set out there where each of the ICPs within the ICS has got to against a range of targets, including A&E attendances and non-elective spells. But it's just there for information, really, and happy to take any questions on that. In terms of why we're here today, then, and some next steps. So the whole purpose was so that the governing body had oversight of the ICS submission that had gone in and the implications or impact from a CCG perspective. Moving forward, we'd expect these plans to be monitored through the routine performance reports that we produce that are shared at both the governing body, the executive committee, and through the ICP executive management group, given that a lot of the measures are actually performance managed at an ICP level. When there's any variation from the expected level of activity or key performance indicator, we've got a range of forums where we can take a remedial action or look at putting mitigations in place. They would include the ICP planning group, the joint performance clinics that we've now got in place with our FTs, and subject-specific task and finish groups where activities span a range of providers or out into community and primary care settings. As Mark's already touched on, we're still awaiting further guidance around H2, and obviously we've seen a resurgence of COVID cases in the community, which will inevitably impact on what we can deliver both in terms of activity and performance. So there is an expectation that at some point, as we run into H2, there will be some kind of refresh process, which might actually look like a whole another planning round taking place in the second half of the year, which would be a challenge, but something that we'll just have to work through. So that was pretty much it from myself. I'll stop sharing the screen and then happy to take any questions, Pos.
Thanks, Craig. So the pages you've showed us are plans for levels of activity.
Yeah.
Are we far enough into the financial year now for us to have some actual levels of activity to compare against plans? You talked about actions being put in place if necessary if we don't actually deliver those. Have we got any history now to be able to compare?
Yeah, I mean, we're jumping a little bit into the performance report as well, because in there we'll start to talk about the number of waiters and elective recovery. So there has been some good progress. We've been able to reduce the number of long waiters that are in our system, in the T's system, and that's really positive in terms of generating elective recovery funding. We've done well as a system in the first month, possibly the first 2 months of the year. I think what we're starting to see now, and in line with the information that you shared in your briefing, we are seeing an impact on the elective programme. So there has been numbers of surgeries cancelled, mainly on an ad hoc basis in the Tees Valley at this stage, where individuals are either having to cancel the surgery themselves because they've tested positive or they've pinged on the app, or where individual staff members are unable to come into work and therefore there's been nobody who can cover for them. So a theatre list has been cancelled, but there hasn't been, within the Tees Valley, any whole-scale cancellation of the elective programme. We know that that has happened elsewhere in the North East and North Cumbria, so that's a positive. But obviously, in terms of the elective recovery fund, we are managed as a whole system, the ICS. So we need the whole North East and North Cumbria to deliver the levels of activity it committed to generate the income that we would then be relying on to pay for some of the activity that we've got going through the independent sector and anything that's above contract.
So how far back do we need to go to actually get data? Is it 3 to 4 months?
In terms of the activity data,
yeah.
So there's a couple of different different ways of looking at it, and we do actually get a weekly feed now. We get something called the WAR, the weekly activity return. The issue with that is the validity of the data, so the levels of coding and is it allocated to the right CCG, etc. So there are some caveats around that, but that does tend to be what we use to inform the direction of travel, where we think we're going. And if we need to take any remedial action, that would be an early warning sign. We wouldn't wait until we were 3 months down the line, we've got the validated SUS data, and then say, oh, look, we had a problem 3 months ago.
Yeah, great. Lovely. Thank you very much. Anybody else got any questions to Craig or to Mark? No? Okay, so that's been noted, and do you need that approved, or is it just for noting and information?
I think from a plan and performance perspective, it's mainly around noting. The approval sign-off process this time has been through the ICS, but obviously there is an impact on the CCG because we're talking about what our contracts are expected to deliver and what we're doing on behalf of our population.
Okay, thanks a lot. Right, okay, moving on. Revised draft terms of reference, Quality Committee. Over to you, Jean.
Thanks, Pos. So in this case, I'm actually stepping in for Jackie, so I hope I can do as good a job as she normally does. It's quite clear on the front sheet what we're bringing here, and we are requesting approval of the revision to the terms of reference for the CCG Quality Committee. We would like to change the frequency to bi-monthly with the aim of holding a minimum of 4 meetings a year. That gives us the flexibility that we've had during some of the pressures of the winter around about COVID, but even allowing for that, we still want to have that minimum. We did recently have a large-scale workshop with a number of colleagues who joined this meeting. So although it's still a CCG meeting, we are inviting our NHS major providers to that. So it's what it says on the front sheet. We'd like to change it to bi-monthly, and behind this you've got the actual terms of reference for the committee. But happy to take any questions.
Apologies, I was muted. And the changes are highlighted on the document as well. So everybody had a look at that, and are you happy to approve that, or are there any questions or comments? Hi, Dave. So everybody happy to approve that, and then we'll move on to uncannily good timing from Dave.
Thanks very much.
Thanks, Jean. And we'll move on to your bit, Dave, Integrated Care System Development update.
Thanks, Pos, and good grief, that doesn't happen very often, does it? Never mind. That's accidental, I have to say. So, yeah, so thank you. So, colleagues will probably recognise quite a bit in this paper. It's really just an opportunity to pull together for us as a governing body things related to the health and care bill that's on its way through Parliament, and it's now had its second reading, but also pertinent to that and pertinent to ourselves as a CCG, the changes proposed around integrated care systems. So the bill started moving through Parliament, as the paper describes. It's had its second reading now, which means that there was a bit of anxiety about whether it would get through the second reading before the parliamentary recess for the summer, because that would add extra delays to the process. But it's on its way through, and now goes into that piece in the summer where there are various committees and discussions that help shape what finally comes back to Parliament. So it's on its way through the process. The paper outlines what integrated care systems are about, basically, and the 4 key functions proposed there. That are on page 65 of the bundle, improving outcomes in population health and healthcare, tackling inequalities, which you know is a huge issue in Tees Valley, making sure that we get the best out of the money that's put into the NHS in terms of productivity and value for money. And a really important one that's kind of been neglected a little bit in the past in terms of the NHS having a bigger part to play. As I think that the parlance at the moment is an anchor organisation and actually contributing as an employer, apart from anything else, to the wider economy and the economic challenges that again are well known and well rehearsed in Tees Valley. There's been an operating framework published by NHS England that describes some of how this will work. And some of the features are about the Integrated Care Board, as it's now called. So there's another three-letter acronym there, which is the statutory board for the NHS, which in our case would be for the North East and North Cumbria. But also an Integrated Care Partnership, which is a little unfortunate because we've worked on Integrated Care Partnerships, meaning the 4 footprints that we've worked on across North East and North Cumbria. But the Integrated Care Partnership is the broader partnership that would sit alongside the Integrated Care Board and provide advice and direction and how that would work. There's some stuff come out in terms of clarifying the roles and responsibilities of ICS, which most of us will recognise the statutory responsibilities are spookily close to, if not the same as CCG responsibilities. And I think that just highlights that some of this is about moving commissioning and other responsibilities for CCGs, the 8 of us in North Cumbria and the North East, across into a different organisation, the ICS. There's some information there in terms of what the composition of the Integrated Care Boards would be, which has got a de minimis arrangement of a chairman, a chief exec, director of finance, medical director, nursing director, other non-executive directors to be worked through, but also at least 3 chief exec level board members, for want of a better phrase, from NHS Foundation trusts, from primary care, and also from local authorities. So while we're getting into some of that and that unitary board, there is the scope to make that bigger if we want to in Cumbria and the North East. The balance, I guess, is the more people you have around the board, the less functional it can be. So there's some conversations going on just at the moment, and I've just come from one, which is apologies why I'm late, with the different local authority groupings, the LA7 so-called to the north of us, and the Tees Valley local authorities, to get into a discussion that will build on the engagement events that we've had in the 4 patches to try and work through how does this work locally and how does the new organisation integrate with local ways of working. So within this, there's a transition programme and some development which is essentially looking at what needs to be done to get to the 1st of April next year, and probably beyond that in terms of safely moving across the statutory functions and responsibilities, the commissioning responsibilities of CCGs, but also some of those of NHS England. So general practice as part of primary care, and then probably to follow the year after potentially the other 3 elements of primary care, which are dentistry, optometry and community pharmacy. There's also a suggestion that some other of the direct commissioning functions of NHS England will move across in time, including some of the specialised services that are commissioned at the moment at a regional level, not the national stuff on heart transplants and some of the really rare conditions with very few patients, but some of the things more locally, and particularly some of the things where there's a bit of debate sometimes between does the CCG currently commission it, or does the specialised commissioning team commission it. Some of that's around, for example, some of the cardiac procedures that, depending on which provider provides them, could be specialist commission or could be CCG. So it should simplify some of that. One of our key concerns, or my key concerns, is that given the transfer of responsibilities across from CCGs, which in all intents and purposes dissolve subject to legislation being agreed at the end of this financial year, is working with the staff to make sure they understand things as they develop, understand the implications for them, certainly understand the employment commitment that's being given to the majority of CCG employed staff, that they would have a commitment to being employed within the new organisation, and working through with them what that means to them and how that works. And we're doing that by a number of routes. We're actually using regular briefings that we have. So we have a fortnightly briefing with staff that a lot of governing body members have joined on occasion. We're supplementing that we also have our weekly written briefing, but there's an ICS-wide briefing that comes from Alan Foster as the executive lead of the ICS, but also from the 3 accountable officers for the 8 CCGs, to put a briefing out to staff every week. And frankly, even if the message is there's nothing to brief this week, we're still putting that out so keeping people in the loop. We're also using our staff events, and where needed, we'll have ad hoc briefings to pick things up. There was an example that I think Mark chaired while I was on leave, where there's a raft of information came through, so we actually took the time out to sit with staff in a virtual nature, obviously because of COVID, to go through what was coming out and what that meant. So lots and lots of work with the staff for them to understand that and to carry them along with this, and to hopefully to be assured and to feel safe in the moves that are suggested by the bill. The timelines are there in the paper. One of the key milestones is now actually passed in that, and we've just sent a note round, copied it round to governing body colleagues, that Salim Donaldson, who was being the chair of the ICS, because he's been through a due and formal process, has been recognised as being officially the chair of the ICS going forward. And then there'll be some HR stuff to, as a national process, I believe, to actually recruit and appoint chief execs and the board members to the ICS as well, that will go through. So at the moment, Salim is the ICS. He's the one person that's actually formally appointed to it. Although he has got a team of people, including people from our patch, Ali Wilson, one of them, but others who are supporting them. Probably the last thing to say is we're working really hard, and had a conversation this morning to make sure that when we do the work streams, that we'll work out how we commission, how we do this, how we do that as an ICS, that we've got broad representation from all of the CCGs across all the patches. There's a risk inherent in this, that if you've got an AO director from one area who's coordinating some of this work, that it ends up being their people doing it. Well, absolutely not. It'll be a range of people from across the patch, and we're feeding into that with our directors and our teams. And we've got link directors as part of that to make sure we land this properly. So probably that's a quick canter through that, Pause. Happy to take any questions or comments, and I'll answer them if I can.
Thanks, Dave. There's a hand from Michelle.
Thanks, Dave. So my question is just as far as the system is concerned and the fact that they have to include patients, carers and the public, what thoughts are being given at that system level? The reason I ask is because with the 3 patient groups that the CCG are funding, just how they may well be involved, and just to ensure that the southern voice is heard, because sometimes we look at the system level and it feels as if it's very much coming from the north. It's just to make sure all of those voices are heard. So what sort of things will be in place for that?
Yeah. So, and I've just heard Salim say this in the meeting I've just come from. This is very much about starting and building on what is there locally. So with the best will in the world, it would probably even be short of tokenistic if there was a big ICS-wide approach to public engagement and involvement. There needs to be that for some really big things, but it needs to reach into communities, as you well know. I'm teaching my grandmother to suck eggs, Michelle, so apologies. But I think that the key bit is that where we've got local mechanisms, we just need to have a look at those and hopefully enhance them, because most of the work in health and social care happens very, very locally. So it's not even within places as we describe in local authorities. It's within parts of those places, the communities, the neighbourhoods. And I was part of a conversation with some colleagues from Vaughan and other third sector organisations yesterday, as you've been doing really well for us and our team, getting in and using the the people, the expertise, the links, the relationships of the third sector to continue to get in and get that patient and public voice. So I think we can do that. It would be that the ICS would build on that and draw things in centrally only when there's a need to. Most things will be kept as locally as possible.
Yeah. All right. Thank you.
Thanks, Dave and Michelle. I've just got one query. Is there any emerging clarity as to when the ICS system will be needing to be in shadow form?
I think the national guidance pause says something like in Q3, which isn't that far away. There's a bit of debate about whether it's the start of Q3 or the end of Q3. It's a bit like in the autumn, isn't it? Seriously, though, it's something that we need to work on because there's quite a bit that we need to get into shadow form. I think there's a discussion to be had about the joint committee of the CCGs and if that can help with that, because we're going to come to a point, and in the work that I'm helping coordinate on contracting, for example, there are contracts and there's procurements that need to be signed off that we will sign off as a CCG, but actually that has a bearing on the successor organisation. So some sort of shadow running has to be in place relatively quickly, but there need to be some appointments. For example, the chief exec will be a key one, and some of the directors to be appointed, even if they're appointed in shadow form as well.
Right. Okay. Thank you very much. There's a note from Jessica about reiterating Michelle's points about third sector needing to be involved as well. But Von is involved in a sort of bigger picture from the ICS perspective. Okay. Shall we? Oh, Michelle?
Yeah, sorry, just to jump in as well, it's just to also be aware, it's fantastic that the voluntary and community sector are a good source of communication and participation, but there are many voluntary and community sector organisations that are also delivering health and care services. Yeah. So we've got to be very, very aware of that and how services are scrutinised as well.
Yeah, no, it's both of those, Michelle, absolutely right.
Okay, so thank you very much, Dave. Your report's noted and we've discussed. Any last questions before we go into a brief break? I thought it was a bit pointless you coming and then going straight to a break, Dave, so I thought I'd have you do your bit. If we reconvene at 25 past. Okay? Right, okay. Thank you for rejoining us. Might as well kick off again. So we're on to the finance report for the last couple of months, well, 2 months leading up to the 31st of May. Jessica's here but not able to join us by video. Right, okay. So over to you, Mark, for the finance report.
Okay, thank you. So as you say, this is for the first 2 months of the year, so a relatively brief report today. It's an early stage and there isn't a lot of information when you're pulling together the first 2 months, particularly around things such as prescribing. As I said in the earlier part of the meeting, in terms of the financial plan, we are still under a temporary financial regime, and as part of that, the CCG is able to request some top-up information for certain costs that are outside of the mainstream plan or out of the mainstream allocation. So at present, as part of our month 2 position, we are claiming for additional funds to do with hospital discharge in terms of getting people out of hospital faster and into care home places in the community. And also in respect of the elective recovery fund that we touched on earlier, where we're able to claim for extra activity over and above the threshold. Both of those two are quite sizable sums. The good news is that the elective recovery fund figure for month 1 and part of month 2 is now confirmed. So that's the majority of the money that we're expecting. The hospital discharge programme money hasn't yet been confirmed, but is considered to be quite low risk as it sort of flowed in a similar way through the last financial year. Pending receipt of those 2 allocations, then the CCG is forecasting to be in line with plan, which was our planned deficit of around 4.3 million for the first 6 months of the year. Included as part of that are some efficiencies for the CCG, and based on what we know so far, the CCG is performing in line with that plan, so no major concern in that area. We are working as part of that integrated care partnership approach, so that's in the current year terminology, so that covers ourselves and the trusts. That is leading us to a plan with a small surplus of 0.4 million. You may recall last financial year we took some opportunities as we moved through the months to revisit and redistribute some of the system-wide funding where that became appropriate, just to address financial challenges as they pop up, whether that's within the CCG or whether that is within some of the trusts. And we'll continue to do that to make sure that we can not only get the best value out of that funding, but also address some of those pressures, whether that's in discharge or whether it's in some of the in-hospital work. And the final point really is to say that we are still waiting for some of that clarity around H2, and therefore that does represent a risk for us as a CCG, but in no greater way than it does to the rest of the NHS. But you'll see that we've reflected that in the risk register when we come to review that later on in the meeting. So they're probably the highlights from finance at this early stage of the year. Thanks.
Yep, thank you very much. So nice that we're sort of rolling along the planned line. Anybody got any questions or comments or queries for Mark? No, it's very, very early part of the financial year. So, yep. So we consider the performance and note the forecast. Okay, look. Thank you very much. Okay, over to you now, Jean. For quality and safeguarding report.
Okay then, thank you very much, Paul. On the assumption that everybody has had the opportunity to read the paper, I just want to bring to your attention a couple of highlights. So I think it's good news under the loss to follow-up that the wider system is acknowledging the inherent concerns about risk across the patch. So what we have is some good work done locally in terms of CCG and the provider working together on this concern. I've shared it a number of times at the quality surveillance group, and there is now a wider piece of work looking at this across the whole of our Cumbria North East patch, so that's good. In terms of never events, I've put some information there, but I think it's important to bear in mind that these reports are written quite some time in advance, obviously, to allow for the processes, and sadly we've had another incident reported recently in relation to never events for this trust. It is a retained item. Colleagues will recall from previous content of previous reports, this is an area of challenge for the trust, and they are working on a lot of improvement work, and excuse me, they've also had support from the CCG, and reference there the never event review that's been undertaken by NHS EI colleagues. That report is still subject to some discussion. The trust was stepped down from quality escalation with the exception of the never event work. So moving on, some other things that I wanted to talk about. So under excuse me, under North Tees, we've talked a number of times and also a number of governing bodies in relation to the non-invasive ventilation instance. The good piece of work that the trust is doing around looking at these together with a view to both informing any changes for themselves, and there's been substantial changes in the trust around about this, but also to inform the wider system. We are still awaiting the report that is the summation of that and will allow us to close down the serious incidents. Just a little bit of additional, so you'll see the second paragraph up from the bottom of page 4. There's been an incident involved delayed discharge letters being shared with GP practices. Whilst this is a concern, I think what is a greater concern, this is very similar to an incident that they had in 2018, where there was a substantial amount of work done and also some very good recommendations and actions should they ever do upgrades, system upgrades again. The early indications are that that learning wasn't necessarily applied in a timely fashion. So once again, we're working with the Trust and also working with the LMC here to make sure that we keep our primary care colleagues fully abreast of developments and impact. All those incidents, all those patients where there's been any delays in their discharge documentation have been reviewed to ensure that there's no harm. For Tees, Escombe Valley, colleagues are well cited on the work with both the regulator and also the system support that's going into this provider. I've talked there about the quality board update, and originally when I spoke about this, we talked about there was one nurse from each ICS, and our ICS was provided by the Director of Nursing for Durham. Since then, I've joined that board and I've had another nurse as well in terms of ensuring the oversight, but also ensuring the contribution from, from a wider base. In terms of still talking about tube, you'll see that I've talked about 4.5, the serious incidents. There is a substantial backlog of open incidents that we're looking to secure additional support to work into the Trust to help them, because some of it's a systems issue and some of it's a capacity issue. So obviously if we can get some high caliber capacity to support that, it's both how we would like to work and do like to work as an ICP, but also it gives it's an opportunity for learning on a wider footprint. But if there are some acute providers who can, and I have to say they don't have anyone that they can spare. So this is not that people have got, oh, we've got somebody kicking around who's doing nothing. They are prepared to take the hit for the system, which is what we're all talking about, how we ensure that the system meets the needs of the people that we serve. And then just moving on, lots of good stuff in there about NIAS, which I think you can read at your leisure. County Durham and Darlington, you'll see there under 6.1, I've talked about some rising concerns about maternity related services, and this has been an area of previous concern for this Trust, so we're working closely again and monitoring that. And it should also be remembered, excuse me, that this Trust is still working very closely, as is North Tees, with South Tees, and any of the complex pregnancies do go to South Tees. Just to give you some good news, because we do like to talk about some good news as well. Priory, the independent sector mental health organisation at Middleton St George, that was subject to executive strategy, which is an escalation of quality concerns. And working with the CCG and the local authority colleagues quite intensively, we've helped to improve and also embed those improvements to the extent, so I've talked about in this report that the CQC had been back and we were expecting the report from that. We have now had confirmation that that is good. So that is a good category, as in, not that it's just good as in, oh, it's good, but they've actually achieved that categorization of good. So I think that's really excellent news. It's excellent for the provider. It's even better for the patients. And it's a really good illustration of what happens and what we can achieve when we all work together. Waterwick Hospice continues to be a source of much concern, and also in receipt of a tremendous amount of support from both the CCG and the Trust that they're co-located with, and also other partners. As things stand at the moment, our wider hospice colleagues are taking adult patients, and the children, of course, there are only 2 respite inpatient options a week as per guidance from CQC. And I think that's largely it. I'm sure colleagues will have questions, so I'm happy to take those questions. Thank you.
Okay, thank you, Jean. Any queries or comments? Just picking up the last issue in relation to Butterwick Hospice, the distances that or other services that are able to pick up the sort of the gap while Butterwick Hospice is worked with, you're working with Butterwick Hospice to, and the system works with Butterwick Hospice to return to its previous position?
Sorry, Pos, I can hardly hear you because you're
Oh,
very
sorry.
quiet.
Yeah, my microphone. In relation to the Butterwick Hospice issue, what sort of distances are patients potentially having to travel if they're needing inpatient care? You mentioned the adult provision, but what about children's provision?
Okay, so Butterwick, they're registered with the CQC to provide both adult inpatient care and children's inpatient care, as well as community delivery of community care. In terms of adults at the moment, we do have a number of other hospices within the Tees Valley footprint that they can go. Also, not all hospice care has to be inpatient care, but the other hospices are supporting those patients because, of course, it's all around the patients and also the families. In terms of children, we're advised that there is children's capacity at Durham, but that is subject to further confirmation. And there is definitely children's capacity in Newcastle. If you check on the CQC website, you see both of those hospices are registered to take children, but then whether they actually do or not is another matter. So we do know that there's children's capacity in Durham and Newcastle. We do have a another children's hospice in Middlesbrough, but it only takes up to age 5, but it tends to focus on the even younger. And obviously the nature of some of the children's illnesses, you do need that additional capacity. But at the moment, because of the concerns about the quality of care and the regulatory quality compliance, there can only be 2. And these are paediatric patients for respite, so they've got to be well known by the hospice, and there's got to be detailed discussions before those children can have that care at Butterwick.
Okay, thanks, Jean. Anybody else before I move on to another question? So you've been describing an effective quality monitoring process that we've got for our CCG. Presumably yourself and Dave particularly are feeding back up the line in relation to the ICS development. The fact that we've got what, certainly to my mind, is a system that assures me that we've got a good way of monitoring quality and encouraging reflection and change in our providers. But can you assure us that you're doing what is needed to plan for the forthcoming future in the ICS?
Okay, well, first off, thank you very much for your kind comments, and I'll feed them back to the team because obviously they do the work. In terms of sharing that and feeding that back, there are a number of work streams underway. So Margaret Kitchen, from the Chief Nursing Officer from NHS England North, has implemented a number of pathways really around work. Some of it's around leadership, some of it's around quality. There's also national pathways around about what does safeguarding look like. Many of these are statutory responsibilities, but how will that be delivered? Now, across Cumbria North East, we've got a number of directors of nursing who are getting together, and we're sharing, because what we're finding is everybody does it their way, because their way has evolved for the benefit of their system and their patients that they serve. So there isn't an actual template that works brilliantly over here that could work just as well over here. A lot of these things are bespoke, and if we think about the focus on localities for of the ICS, that is what you'd want to do. But what looking at these things is doing is there's a lot of sharing of good ideas. And also we're thinking, how do we keep what we've got if it works? How do we flex what we've got if there's some additional bits that would be better? How do we assure ourselves? So reflecting on the assurance that we have Is that valid? Is that robust? And then also, how would we flow that into a wider system so that it's comparable elsewhere? So in answer to your question, yes, that work's underway. Yes, I'm part of it, as are my other Director of Nursing colleagues from both Cumbria North East, but also the North Yorkshire area as well. So we really have, we're swimming in a very rich pool at the moment.
Thanks, Jean. Anything you want to add there, Dave and Andy?
No, I think Jean's described quite nicely, Pos, and I think we've developed with Andy's leadership an approach to working across a patch in Tees Valley that could stand the test of time moving forward. So, yeah, we just need to keep on working with colleagues in other parts of the system.
Thanks. Andy?
Yeah, I think we're finding it is a challenge, but I suppose under current circumstances, it's bound to be. But the trusts are working really hard, and that's the main thing.
Okay, thank you very much. Quality and safeguarding received and considered. Safeguarding bit you didn't particularly pick up on. Was there anything that you wanted to add there at all?
I think when it comes to safeguarding, Pos, intermittently what I do is I talk to colleagues about some of the challenges. Much of the safeguarding work is high intensity and quite concerning, but that is routinely the case. Some colleagues may have seen recent publications last week, this week, in terms of impact of child poverty, deprivation on child protection, etc. We haven't got time to go into it here, but obviously some of the deprivation indices that we're working with, that has an impact on that from both children's and also an adult perspective. But we just continue. That is the day job, but it's an enormous challenge. And that's why we work with our local authority and police colleagues on that. That just goes on. This report is always exceptional exceptions rather than the routine exceptions, but always happy to pick up any points that colleagues may have or questions. So we've still got a lot of domestic homicides that we're working through in terms of investigating. We've still got a lot of safeguarding adult reviews underway. We've got a number of child, what we used to call serious case reviews underway. We have a substantial open caseload of child deaths that are underway. What we do with that, so that colleagues know that that's very visible, that goes to the CCG Quality Committee, where we also have other wider providers that, so that the senior awareness, citing, actions, etc. Is very much more at an operational level rather than an exec committee like this.
Okay, thanks, Jean. That gives us a nice flavour of what goes on in the background. Thanks a lot. Right, lovely. So that's quality and safeguarding report received and considered. Next up, Craig and the performance report.
Thanks, Pos. Yep, the report's included in the pack, so I was just going to run through it briefly. Some of the issues that we'll touch on have already been touched in part through other updates, including yours and Janet's earlier today. So if I can just start with the update around infections. If you could just indulge me for a second, Pos, the slide that was included in the pack was the latest available information we had at the point the report needed to be produced. But obviously we get a daily feed on the current rates, and actually we've got a more up-to-date position now. So if I can just flash up on screen, if that's okay, the latest available report, and we can share this information afterwards. But just so that people are aware, you touched earlier on that we've seen that spike in case rates across the Tees Valley. The chart that's on the screen, and hopefully you can see that, it might be a little bit small, but like I said, we'll share afterwards. You can see that we have peaked in the Tees Valley around 1,275 cases per 100,000. That has started to decrease significantly over the last week or so. Now that's not saying we're coming out the other side of this latest wave, but what we are seeing is a reduction in community cases at this point in time. That will not reflect the outcome of the easing of social distancing rules on the 16th of July. So it may be that we see yet another peak, but it is encouraging I suppose. And given that you'd highlighted earlier on, we seem to have broken that coupling between community cases and hospital admissions. So again, that's something else that we should cling to as a bit of hope for where we go next. So I'll stop sharing that now, and we'll go back to the report. Apologies. Great. So that's the latest available position based on yesterday's reporting on the number of cases. Moving forward then, daily vaccine data, it is what it is in the pack. We're continuing to roll out the vaccination programme. Janet's already touched on that, so there's not a lot to add. Just summarising the position at the 28th of June, there was over 770,000 vaccines, 340 of which had been for a second dose, which is great. The cumulative comparisons of vaccines, both first dose and second dose, paint a slightly different picture. Over 65s, very positive. Under 65s for the first dose, slightly behind the national average. And again, that relates back to the points Janet raised around inequalities and trying to get out into particular hard to reach communities, etc. In terms of the second dose though, which is detailed on page 116, we're actually ahead of the national averages, which is really positive. So those who are coming back for a second dose seem to be in advance. Janet, I can see that you got a bit of a look on your face. Is there anything you wanted to say or add?
Do beg your pardon, I must watch my body language, sorry. It was just, there's complexities. It's really important that we do make sure that people are aware of the message that you have your second dose at between 8 and 12 weeks. If you have your second dose under 8 weeks, you don't get the same immune response. So whilst I appreciate, yes, those people that are desperately keen to have it, to do something, there is a need to make sure that, yes, people don't try coming early for their second doses, and that we are very much sticking to the party line, that you get the better immunological response between 8 and 12 weeks. So you will be called at or after 8 weeks. And yes, please don't present trying to get it earlier, because that's not good for your body's response to it.
Thanks, Janet. Point to clarify that. Okay, so moving on in terms of activity levels, we touched on the ERF, the Elective Recovery Fund earlier on, and we've just given a brief update there of where we've got to. So the April confirmed positions around ERF and the activity that's gone through, but some headlines in terms of the latest available information. So Pos, you'd asked around, do we get a more contemporaneous update in terms of where we are? At the point the report was produced, we had data up to the end of June. Obviously we've moved on from that now, but you can see where we were. That was obviously just ahead of the latest peak as well. So things have slowed down a little bit from that point, but we're hoping to recover as the number of community cases drops back again. In terms of some of our key performance issues, they continue to be around referral to treatment times, the RTT long waiters, and the 104-day cancer waiters, so patients who've waited longer than we would have expected to receive their cancer surgery. RTT, it's an improving position because we have seen some reductions in the number of long waiters, but it does fluctuate in month and from month to month. So again, at the moment, given some of the pressures on the acute system, secondary care providers, then our progress has slowed, but South Tees had started to make some good inroads into the significant backlog that they'd had. And we're also continuing to work to support movement between South Tees and North Tees and some of our other providers for those longest waiting patients, in particular around orthopedics and spinal surgery as well, which I'll be able to update on at future meetings. In terms of cancer, the actions that we'd outlined previously continue to be taken, and there is actually a little bit more detail in the appendix of the performance report as well. Just touching on the performance report, what we've tried to do is update the look and feel of the report to help with our approach to targeting some of the interventions we take, Pos. So there's some guidance notes included in the appendix under page 121, which basically outline the approach we're trying to take using special cause variation, so that we don't raise queries and questions with all of our providers every time there's a variation from a plan, but we look for some special cause trend analysis really, and try and identify those key underperformances or overperformances that warrant some further investigation. This is an approach that will be taken forward with all of our providers, and the recently introduced joint performance clinics between the FTs is the key forum for doing that. what I'd like to do at some point in the future is hopefully provide a little bit more of an update to the governing body through one of the development sessions to talk you through the report, how it works and how we can better use some of the information. But as it is, it's there for information today. We have included some of the mitigating actions and discussions that are taking place with all of our providers around any areas of concern or underperformance. And I'm happy to take any questions.
Okay, thanks, Craig. Any questions or comments? While people are thinking, is there anything that we need to be reflecting on in relation to sort of page 118 and the 40-week and 52-week wait times, differences between North Tees and ST, South Tees and CDD-FT particularly? Is there any lessons to be learned or systems, things to spread around?
I think it's a really complex position, and to do it justice in a couple of minutes would be difficult, Pos. But I think yes, there's absolutely stuff that could help in terms of joint PTLs. So we're currently piloting. So PTLs are patient targeting list or patient tracking list. They have slightly different names in different organisations, but the tracking list is used to manage patient waits within an organisation. And what we're currently working on at the moment is a single PTL in urology across North and South Tees. So we're just looking at the infrastructure required to support that, so that we can identify those patients who've waited the longest with the greatest clinical need across a number of those waiting lists, and then prioritise them for treatment. This is based on some learning that we've took from the cancer cell, the cancer surgical cell that operated during COVID, where we were trying to prioritise the available theatre capacity for those patients with the greatest need who were waiting for cancer treatments. So I think some good learning come out of COVID there that we're looking now to apply across the broader waiting lists. Obviously, the big area for us is orthopaedics. The bulk of our waiters are in and around orthopaedics. But to crack it in urology would give us some great learning that we could then apply to other surgical specialties as well.
Because certainly if I was viewing this from a patient perspective, I'd be sort of wanting the CCG to be facilitating whatever learning could be spread across the system in view of the difference between the two. So obviously an area to keep an eye on for future performance, I think.
Yeah, there is I suppose there's a role for our patients to play with this as well, and to help us with it. So South Tees recently contacted around 400 orthopaedic long waiters to offer them the choice of surgery at an alternative venue, predominantly the independent sector, and we had a really low uptake, patients choosing not to go elsewhere. Now obviously that is patient choice, and they're well within their rights to do that, and every patient who is a long waiter will be reviewed. There'll be a harm review to make sure that there's no further harm being done to that patient as a result of the waiting time. But yeah, if patients are willing to move to an alternative provider, then that is something we can help facilitate.
Okay, Michelle?
Just on the back of that, Craig, was there any feedback as to why they didn't want to?
Yeah, so continuity of care. So staying with the consultant that they'd already seen in outpatients or had previous treatment with was one of the key areas that was mentioned. But also there is some concern out there around coming into hospital at the moment, especially while there is resurgence of COVID. And we can provide assurances around systems and process, but what we can't do is remove that fear factor that's out there with the public at the moment. And there is a perception that obviously somewhere like North Tees and Hartlepool, Cheltenham and Darlington and South Tees FT, that there's all of the backup there for critical care and whatever else goes with that. Some of the independent sector providers don't have the range of facilities. Now they are safe, effective services commissioned to provide these treatments and interventions, but I think there's something around public perception around, if this is where patients are being cared for when they've got COVID, then perhaps that's a better alternative for me. So it's just, I think, sharing information with the public, making sure they're aware of the waiting times and the implications of continuing to wait, and trying to manage the situation as best as we can, putting on additional capacity where that's available, and making best use of all of the hospitals that we've got right across the Tees Valley, which also includes the independent sector.
Yeah.
Okay. Thanks, Craig. I can't see any other hands up, so we'll receive and consider your report and note it. Thank you very much. Okay, now moving on to the governance assurance and risk report. Over to you, Mark.
Okay, thank you. So I'll just run through some of the main highlights in this report. The first element is in terms of risk. So all the CCG risks have been reviewed, and you recall that we considered a revised risk matrix and definitions, so they've now all been mapped against those and also mapped against the new corporate objectives. So that's a bit of a clearer record really of the risks and how they then map through. There are 21 risks in all. Some of the key changes that are on there, the risk number 2, which is about non-delivery of the in-year financial position, we've increased the likelihood on that risk to a 4, and that's fairly routine or usual for this time of the year, and also builds upon some of the discussion we've had around the uncertainty of what H2 second half of the year looks like. So I think that feels appropriate at this time. There's also a risk that's been increased from a 3 to a 4, which is in terms of likelihood around whether demand on available capacity will affect constitutional standards. And I think that links to some of the points that Craig's been pointing out in the performance report so far. There's also the risk on the risk register around the coronavirus outbreak and the scope for that, or the potential for that, to interrupt the business of the CCG. Now, we've actually reduced the likelihood of this, bearing in mind that it's focused on the business of the CCG, and that we've been working in terms of our hybrid working arrangements, the deployment of the vaccine, the fact that people are able to work in different places, and our experience over previous months has meant that we've felt that we could reduce that from a likely to a possible at this stage. There is some closed risks on the risk register. We've closed off the risk to do with EU exit. We've had several months post EU exit now, and it was particularly focused on the supply of medicines and goods, which hasn't had a material impact upon the CCG to date. We've closed off some arrangements that we had in place around discharge patients and challenges or backlogs of assessments. The work has been done to recover that backlog, which is great news. That's now been cleared, so we've been able to clear that risk. And we had a risk related to unexpected cost pressures related to learning disabilities, discharge from specialised services. So we've removed that risk purely on the basis that it's embedded within operational processes. But as ever, we'll keep that under review and bring it back onto the risk register if appropriate. There are a couple of risks under consideration. One is in respect of Butterwick Hospice and the children's services that we've mentioned previously in the report. And the second one was around practices terminating contracts, risks in terms of partnership breakdowns. So both of those two currently being worked upon in terms of addition to the risk register. Also in the report, outside of risk, there's a section around equality, diversity and inclusion and EDI, and there's some training and unconscious bias training that was delivered to around 60 of our colleagues in the CCG at the July staff event, and this is something that we'll be taking forward. We've also considered our health and wellbeing conversations and the one-to-one meetings that we have with staff, so that we can explore some of those issues and discuss issues relating to equality, diversity, inclusion, and also unconscious bias. One of our items that's come through consistently in our discussions with patient and public involvement is about links with some of the seldom heard communities. And indeed that was picked up in one of the recent meetings, which I think Michelle attended around the patient and public involvement. We referred to that, that was the one arranged by Jake earlier in the meeting. Couple more points to pick out. Hybrid working, we've been continuing to work with staff so we can safely return to the office. Hybrid working supports really the management of the risk and the balance between working at home, working in other places and working here in the CCG offices. And then a final point to do with the data security and protection toolkit. Just some good news to say that following a very rigorous audit process, the CCG had a fully compliant submission and received an audit rating of substantial assurance, which was excellent news, and congratulations to all the staff involved in delivering that.
Great stuff. Thank you very much, Mark. And so we're to receive and note that, which we do. And do we need any further information or assurance in relation to our risk position? I think actually that I feel that what you're describing is what I feel in relation to our risk process. So I don't feel that I need anything extra added at the moment, and there's a process in place to sort of, particularly in relation to staff input and feedback, seems to be working pretty well. Does anybody else have any other questions or queries before we receive this report? No, thank you very much.
I think positive, just to say that there's some reassurance in that when we receive and hear the other reports that are on the agenda, you can see the links between the risk register and those reports, and that really helps with the clarity, I think.
Absolutely. Yeah. Thank you very much. So now we move on to the items for information. So if any of the chairs want to flag anything in relation to the committee reports that we've got here, Audit and Assurance Committee, Exec Committee, Primary Care Commissioning Committee and Quality Committee. Does anybody want to flag anything from there? No? Okay, thank you very much. And items to note, the CCG minutes from the Audit, Executive, Primary Care and Quality Committee, and other minutes from the Hartlepool Health and Wellbeing Board and Stockton Health and Wellbeing Board. Anything to flag from there at all? No? Okay, so received those. Any other business? We didn't have any other business. Oh, sorry, there's a comment here from Joe Bushnell. Should unconscious bias training be added to our normal training? I think that's probably included to a degree in our diversity and equality training, just on reflection. So it's probably effectively included in our mandatory training. Yep. Okay. And any consideration on any impact on our register before we go to members of the public questions? So anything to change or affect our risk register? I can't think of anything here just at the moment. No. Okay, so folks who are in attendance at this meeting, anything that you want to raise? At all, questions or comments or queries? Here's your opportunity. Anybody want to raise or query anything? No. Actually, Nick Marco isn't here this time, which is unusual. Anyway, right. So, any other comments or queries? No, or forever hold your peace. Excellent. So. I'll wrap up this meeting actually slightly ahead of time. I can't believe it. So thank you very much for your attendance, everybody. And was there a microphone coming live? No. Okay. So thank you very much, and we'll wrap up slightly ahead of time. And our next meeting is 22nd of September.